Thank you, Carolyn. That was appropriately understated. It's October 1st. It's the beginning of a new month and a beginning of a new year for us in this community, and I'd like to thank you all for coming and thank Mr. Roy for his comments and give you my usual update, but I think with a new vested enthusiasm of things to come among the theme of this thing. So welcome to 2015, and note that this graphic actually demonstrates the intricacy and the complexity of the things that we try and do, all with the idea of helping make it better for patients. This audience probably doesn't need to be reminded, but I will, that 1 in 10 people in British Columbia have kidney disease. That kidney disease is a complex disorder, and I'll give you some examples of that, and that our model of care is unique nationally and probably internationally. We have a governance and funding structure that is different than most. We have a network of multidisciplinary clinics and committees, which I'll show you, and we've had a number of accomplishments, and we continue to have challenges, but together I think that we actually will continue to keep the patient in the middle and do excellent things to improve the care of patients. So this is just some numbers for you. We have 13,000 people with chronic kidney disease registered in our programs. That is seen by nephrologists or nephrology teams. We have 3,015 who actually have kidney failure. That is on dialysis, and I'll let David tell you about the transplant numbers. And 50 years ago, which isn't for some of us that long ago, it was actually a death sentence. So the fact that we actually have this many people and we actually can offer hope and therapies is quite an impressive change. So kidney disease is a complex disorder. People are whole people and they actually have many other things wrong with them, and therefore taking care of these people is not as simple as taking care of one organ system. Furthermore, they have multiple interactions with lots of different groups and facilities over time, not just hospitals and dialysis units, but GPs, general, other specialists, and they have a number of different interactions. It makes taking care of people with kidney disease relatively complicated, and I think we need to pay attention to that, and that's much of what we're trying to do as we go forward. If we take the patient's perspective, imagine that they're trying to get to appointments, understand the system and their treatment options, manage their disease or diseases, understand the 15 or 20 medications we give them, and all the time struggling with pain and symptom control. And from our perspective as a healthcare team, what we're trying to do is make sure that we actually identify them, refer them. Our job is to delay progression or help to delay progression, make sure they select with informed decision-making the right modality and start at the right time, and try and establish a community of care. These perspectives go together, but you can imagine, as Mr. Roy was saying, is that the way that we structure the system and what the patient is dealing with don't always jive. And I think we've been struggling and trying to make it better for patients in a number of ways, trying to really look at the patient's perspective. And what we've spent a lot of time in this province doing is looking at chronic disease models and having and developing care models that integrate the complexity of the clinical condition, a patient-centered philosophy, and the healthcare environment. And I believe that principles of care are universal and that how we implement is actually customized to the specific circumstance, be that the patient, the region, or the actual unit that they're working in. And I like this definition of optimal care, and I think the Ministry of Health does too. It's that care that leads to the best outcomes for the individual first, the population, and society as a whole. And that's a tall order. In order to do that, there are 5 major requirements. We need to scientifically understand the disease, and for that reason, we need to have research, both basic and clinical, at the core of the way that we do things so that we can always improve our understanding and then tailor therapy. We need to be able to identify the diseases and the patients at risk and know which are the best therapies and strategies and have our quality metrics and evidence-informed practice. And I know those sound like words, but the reality is in this province, we certainly do have regular review of what we're doing, how we're doing it, how to do it better, and where possible engage in research projects that actually help us get answers that we don't have. And then the bigger challenge is being able to deliver effective therapies in a timely manner. And our example of timely referral to preemptive transplant and increasing living donor access, these are all things that we together as a community are attempting to do. But ultimately, you need a supportive health environment where we align the funding, the information system, and decision support together. And this is something called the chronic care model that many of you will be familiar with. I think in renal, we're the closest I've seen to any other system of actually really trying to get these various components together. Is it perfect? No. But I think we do have, with the funding model alignment, the dollar following the patients, not the programs, and the information system, a way to actually try and do all this together. So the BC Renal Agency vision and mission that we, I think, all share is that we have an innovative integrated health system resulting in outstanding care for patients living with kidney disease. Our mission is to integrate knowledge and practice for better kidney health. And you'll notice the word disease isn't there, and that's intentional. The way we've structured the renal agency, many of you have seen this picture, those of you that are new have not, but patients and the community they live in is in the center of this diagram. And that's because that's the only reason that we're here. And people do not exist within a healthcare system, they exist within their community. We happen to have health authorities, and within those health authorities, we have renal health authority programs. And then the renal agency helps us to try and keep everybody on track. So the health authorities have the operational responsibility to deliver the programs, and then we have the overarching support from the renal agency. We have 6 health authorities. If you're wondering what the 6th one is, it's the children's, because they count as one planet unto themselves. There are 11 home hemodialysis training sites, 12 PD dialysis clinics, 13 hospital dialysis units, 14 CKD clinics, and 27 community dialysis units in this province, which you know has a diverse and challenging geography. Dr. Roy already alluded to some of this, but our increase in access to care for kidney patients is demonstrated on this slide. I'll draw your attention to the 10-year increase in the number of people that we know about or are registered as chronic kidney disease or so-called pre-dialysis. Hospital-based dialysis has been increasing about 3% per year, home-based 7% per year, which is pretty terrific. And we've had this huge new increase in facility-independent nocturnal, as well as a novel facility-dependent nocturnal hemo within the facilities. And so these are all ways to try and deliver better care, customized to different patient needs, and recognizing that not one size fits all. We've been restructuring and realigning our provincial committee structures. They have a similar name, and it's clearer who's on them, and I won't go into all the details, but importantly, this sort of circle of networks actually then functions by virtue of all these committees, all of which are populated by people from each of the health authorities and with different disciplines. And I think that cross-health authority and multidisciplinary group that meets within each of these is part of the reason for the integration and success. So this is a busy slide, but serves to just remind us that there are a number of highlights, and you'll hear more about them. But the Kidney Care Committee has published a highly accessed document called Best Practice Guidelines for Kidney Care Clinics. There are prescription pads now where pharmacists know that you have kidney disease and it gets registered in the pharmacy system so that the pharmacist can't prescribe or will be alerted to not prescribing you certain drugs. There are now anxiety depression guidelines and a standardized modality options education tool which has been emulated by the country. The PD committee has just completed a PD assist group, as well as some standardized e-learning modules, and has hosted Western PD Days for quite a while. The Home Hemotherapy Committee is actually looking at the next stage pilot and has a provincial rollout plan for that, and a number of different guidelines. And the newly formed Hemodialysis Committee is now actually putting together their best practices guideline and a number of other initiatives which help to share best practices, as well as a standardized around the province hemodialysis patient welcome package, which should be quite terrific so that no matter which unit you go to, something will be relatively standardized, and all those people that spend time trying to figure out what goes in that package will have some guidance and some guidelines for visiting patients. You'll hear more about the Glomerulonephritis Committee and all of the tools. These are all firsts. Nowhere in Canada do these provincial committees exist with this overarching access to both patients and clinicians and other healthcare providers, this amount of information. And we have an outstanding palliative care committee also functioning to help us look at standardizing our approach to palliative care. The Pharmacy and Formulary Committee, as alluded to, has actually led us to a number of cost savings, as well as you'll hear later some framework for evaluation of novel diseases so that we actually can have equitable access to new medications for patients when they come. And we have a number of philosophies of medication funding policies so that we actually safely deliver drugs that are needed in our patients but can be potentially dangerous. And there are a number of other initiatives which you'll hear about throughout the day, but I think just speaks to the breadth and depth of the activities of this community. And so why the network works, I think, is A, that there's a patient focus at all times, and I think most of you, if you've ever been on a committee when we're trying to design something new, the question always is this going to make a difference for the patient? Because if it's not, we're faffing around and we just need to stop and reorganize ourselves. We have a matrix governance structure, so that's a good thing and a bad thing. So we report to multiple people, health authorities, institutions, renal agency, Provincial Health Services Authority, and yet I think that perhaps keeps us focused and maybe singing from the same song sheet. We have protected renal funding of 169 plus, it's about $172 million this year, have provincial contracts, and our dedicated information system, Promise, which is still far and beyond the envy of everyone in Canada, if not internationally, in terms of the data that comes out of it, the way it can be used, and we continue to struggle with various technology issues related to health authority, other information systems, but I think we're working more collegially with all. And then we have a series of metrics that are incredibly useful to help us know where we are at any one time, which is always good. It's a bit of a roadmap for us. This is a busy slide that many of you will have seen. It's the Ministry of Health Strategic Goals and Priorities, and it's very similar to people in the audience if you've seen the UK strategic goals and priorities, which is staying healthy, getting better, living with illness or disability, and coping with end of life. And then there are a series of goals, priorities, and enabling strategies. And I thought it's sometimes interesting for us to map how many of these things we actually do overtly within the renal community. So we are about getting better and staying healthy, living with illness or disability in an optimal way, and coping with end of life. But the really important thing is that we try to deliver a system of responsive and effective healthcare services as a community, and really take it seriously to ensure value for money. And year on year, when we go to the Ministry of Health to ask for an increase in our budget based on our data, we always get it because we have the data to back it up and because we're able to show that we're responsible with the dollars that we've got. And then those other stars are just things that you all know. But this didn't show, so I'm going to can I go back a slide, please? Can you go back a slide for me? Thanks. So if we look at the stars below, what those other words were is that we actually have a number of initiatives that line up with this. Primary and community care, we have a GP education program and ongoing outreach with nurse practitioners and GPs. We have waiting list improvement in terms of access to specialist services and a number of other things that I won't be able to go into because I don't have as... But these are them here in terms of the GN and transplant and the formulary and some telehealth, much of which you'll hear about over the course of the next 2 days. So the strategies that we use to improve outcomes include public awareness, and you'll notice we have a Kidney Smart, Heart Smart campaign, and around Kidney Month and World Kidney Day, we have a number of activities. We have professional education activities such as this. We try and influence policy with our guidelines and instructions with the Ministry of Health, and we are engaging in more and more in terms of facilitating research around the province. So just to close, we have a number of achievements here. We've grown, our dialysis growth has leveled off and is the lowest in the country. 2 to 3% per year is actually terrific, and that's because of a number of different things, not just slowing progression, but appropriate preemptive transplantation in a timely manner, as well as appropriate choice of conservative care. We have the lowest ratio of dialysis stations in Canada, which means we have more people at home than anyone else, which is also pretty terrific. So 33%, depending on which day you want to take the snapshot, are on independent, and we're trying to aim for higher. And we have the only province-wide registry for kidney and transplant patients in the world that actually gets granularly captured data of each patient individually over time. And I think that's something that we need to be incredibly proud of. And the uses for that data, both in real time clinically as well as for other purposes, is huge and at this time still underutilized. We have renal patients do not pay for any medication. That's pretty outstanding. If you're on dialysis, that's enough of a hardship. There are no medications that they pay for. And we have the only outpatient med rec in the country that we know of where there's a medication reconciliation and safety for the patients that truly makes sure that our patients who are on 15 medications at minimum don't get mixed up and don't get the wrong thing done. So we have a patient-focused funding model, our GP education, and all of the province-wide protocols and strategies that I spoke of. And through all of this, we're actually able to achieve the things that we think are important, which is helping people to live with their kidney disease in the most healthy way possible and get the right treatment at the right time. I'm just going to skip. We have been leveraging partnerships not just with BC Renal, BC Transplant, but also with Cardiac Services BC and some official e-health strategies. And we're working on an enhanced renal research network so that all patients can access studies and that all of us can be involved no matter where we are in the province. How do we do all this with those of us in the room? And one of the important things that we believe strongly in is sustainability and renewal. And renewal has to do with people. And so we support a number of fellowships. So there are clinical fellowships that we support. And I've listed Orla and Catherine's names here as our current home therapy programs. They're from Ireland and Australia, respectively. We have administrative fellowships so people can get their master's in health administration and help with some of these initiatives. And Cliff Lowe is finished, but now working with the Renal Agency in another capacity. And Mike Bevilacqua has just joined us for the next 2 years. So we're continuing to renew the group of people with skill sets that can help us go forward. In adult nephrology, we have 3 individuals who are finishing their second clinical year and 2 that started their first year. We have 2 clinical fellows in renal transplantation and 3 in pediatric nephrology. We have new nephrologists in adult nephrology. Yang Zheng has just started in Fraser Health, Scott Lyle in the interior, and Paul Raju in the interior. And in pediatric nephrology, we've been fortunate to get Tom Blight-Hansen as the medical director for pediatric transplant and multi-organ transplant, and that's a great asset to both pediatric nephrology and transplantation, so another example of partnership and collaboration. And then there's a number of the nurses that have actually obtained their CNEF, and too long of a list, and I'm running out of time to list, but congratulations to all of you, because that's quite a feat to actually have the certification in nephrology. So this is the nurses in each of the different health authorities that have managed to accomplish that. So terrific. A clap, please, for them. And then there's a group of people that you don't see, and there's the PROMISE team, the statisticians and methodologists that make sure that we stay on message and have quality data, stay accountable and do the work, and of course the renal agency administrative staff from whom you get multiple emails on multiple days about multiple things, but that keeps us on track. So we focus on patient outcomes, we focus on knowledge translation, and we focus on creating systems that optimize outcomes. And without all of you, there wouldn't actually be this community. So I would like to again thank you for your energy and commitment, really, to people who live with kidney disease. So it's really the renal agency. If you ever get tempted to say they are making us do this, please remember that they are us. And the renal agency is us, not a they. And we're all here doing this together. So thank you very much for your attention and your work. So it gives me great pleasure to actually hand over to the 2 people that will give you the BC Transplant update, Dr. Landsberg, who's the medical director of BC Transplant, and a friend and a colleague, and actually has a number of key roles nationally in terms of transplantation, because BC is really a shining light in the current CBS transplant initiatives, and I think that that's something that we need to very much understand. And then Ed Ferre, who is the interim provincial operations director of BCT. Not sure which of you is going first. So Ed will come first. So there you go.
Good morning, everyone. Before I start, I'd like to introduce someone who's new to PHSA. It's Colleen Hart. Colleen, do you want to stand up? There she is. Colleen is the new Vice President of Provincial Population Health and Chronic and Specialized Populations. In her portfolio is BC Transplant, BC Renal, Cardiac, Stroke, BC Centre for Disease Control, the Trans Care Centre, and First Nations Health Authority Liaison. So welcome, and we had the pleasure of having Colleen with us yesterday for the entire day at a regional clinic and transplant clinic meeting, and I encourage you to introduce yourself to her. All right. So my slides are there. All right. So BC Transplant, well, we're responsible for all aspects of organ donation and transplantation in BC. We're the first payors for immunosuppressive therapy in the province, and we also have stewardship over the organ donor registry in British Columbia. So in terms of our strategic direction, our three primary operational goals that support the PHSA mission are firstly increasing organ donation, reducing the number of patients on the transplant list, and improving how we deliver patient care, care to patients and donor families. And I'll speak primarily to the first one, and David will speak to the second one. So firstly, I'd like to talk about some statistics. In 2005, we're currently at a total of 77 deceased organ donors. So this is now record territory. Our best year to date has been 70 organ donors, and with 3 months remaining, we're about 43% over that number. So by the end of the year, will be interesting to see how we end up. So we've had 56 neurologically deceased donors and 21 donation after cardiocirculatory donors. The number of transplants from these deceased donors totals 248. And as Carl said earlier, we've doubled our transplant numbers since 2009. So what are we doing to increase the number of organs that are available for transplant? Well, expanding donation after cardiocirculatory death to hospitals across British Columbia. Initially, DCD was available in 3 lower mainland hospitals, but we've expanded the DCD program to all of the health authorities. And DCD is operational at Vancouver Coastal, at Fraser, at Island, and Interior Health, and policies are in place to move DCD forward in Northern Health when they identify the appropriate patient. Now, organ donation is completely dependent upon 2 events. Firstly, the altruistic act of consent for organ donation by critically ill or neurologically deceased individuals through either our organ donor registry or consent from their families. And secondly, the referral of these critically or neurologically deceased patients by healthcare providers from our emergency rooms and intensive care units anywhere in the province. The latter of these 2 events is completely outside of BC Transplant's control. So the question to us is, how do we influence this practice? Well, we know that it can be quite difficult for critical care staff when, despite their best efforts, they can't save a patient's life. There's often a feeling of loss, and it's easy for them to move away and withdraw life-sustaining therapy, but that provides no benefit. So the lion's share of the work we do at BC Transplant has been with working with the critical care community to change the culture of end-of-life care and normalize the idea that organ donation needs to be considered and, if appropriate, one of the options made available as part of quality end-of-care life in this province. So to help us do that, we've identified critical care physician champions in all of the health authorities. These physicians work in concert with our in-house coordinators, and at 11 o'clock there'll be a presentation on the in-house coordinators. These work for BC Transplant and are embedded within each health authority to move policy forward within the health authorities. Our donation physician champions also sit in our critical care donation advisory committee. They help develop our donation guidelines and help us formulate leading practice for both neurologically deceased and cardiocirculatory deceased donation. They help us optimize organ utilization, a key performance indicator of organs per donor, And in addition, these physicians are instrumental in helping to educate their colleagues in the critical care community. So some more statistics. These are the number of transplants. You'll see that this year we currently have 334 transplants. This is exactly 100 transplants more than this time last year. So the impact of both increased deceased donation and increased in living donation, both in the kidney, and I think there's been 3 living liver transplants this year, account for those numbers. So to summarize and highlight the stats, we have 77 deceased donors to date this year, 86 living donors, or 83 of those kidney and 3 liver, 334 transplants. We currently follow just over 4,000 patients in the province. Approximately 500 people are on the wait list for transplant, and we're reaching the first milestone of 1 million people registering on our organ donor registry. So, changing culture through education and awareness. Our goal is to create a culture that embraces organ donation. We do this by working to normalize the conversation about organ donation at the end of life, increasing the awareness of the life-saving impact of organ donation and transplantation, and dispelling misconceptions surrounding organ donation. Now, the 48 and 48, one of the recent events during the National Organ and Tissue Donor Awareness Week was a 48-hour drive to register donors. This was a national initiative that was spearheaded by Peggy and our communications team at BC Transplant and hosted nationally by Global TV. And within the 48 hours, we had almost 20,000 people register. So that certainly has a phenomenal impact on our culture. And of course, as I mentioned earlier, we have stewardship over the Provincial Organ Donor Registry. The decision to register can be made online. We have registration forms available at various locations. There's been a new and very successful partnership with Services BC, where all 61 of their service centres in the province now distribute the registry forms for us. And we're also looking at a pilot project with ICBC licensing centres to distribute our literature for us. So, and as usual, we encourage everyone to register and share their wishes with their family. And with that, I will hand it over to Dr. Landsberg.
Thank you, Ed. So I'm pretty sure most people who have been around for any length of time know me and know that I've been here for a very, very long time. You know, I know BC Nephrology Days has been going on, or BC Renal Days has been going on for at least 23 years, because I remember standing up on this podium talking in 1992 when the Blue Jays were in the World Series. So it was, and that was only reminded this morning because maybe there's a shot for the Blue Jays again, and they had lost the game, and I remember they were playing against St. Louis, and somebody hit a home run, and I told a joke about that, and it just went way south. So, but I'm still, since the Blue Jays are back, I thought I would just share that with you. We're a bit short on time. I want to help catch up, so I might go a little off script and just hit some highlights. So this is a new position for me. I've been committed to renal transplant, first at St. Paul's, and then more globally in Vancouver, and to some extent provincially. But this new appointment for me gives, I think, BC Transplant an opportunity to make a real headway in terms of being truly provincial in terms of the way we deliver care for our transplant patients across the province, and gives us a stronger ability, I think, to work in absolute partnership, hand in hand with BC Renal Agency, to really make sure that that journey of our patient is as seamless and as integrated as possible, and will hopefully lead to the right patient getting the right care in the right place at the right time, and we can do a better job of that collaboration. And I really think that those are the opportunities and challenges that are going to come to me. Now, we know for transplant, one of the most important, the bottom line is donation. So if there's no organ donation, there is no transplant. I speak not only for the kidney patients, but all the other organ transplant patients as well. And BC Transplant has done an amazing job over the last 5 years. We didn't clarify what Carl was saying. I think probably most of you figured out that he was the consultant who he was talking about. And so 2009, we were probably at the bottom in terms of our organ donation rate in the country, certainly in terms of our deceased donor rate, maybe not in terms of living donation, but with a real strategic investment in BC Transplant, in getting the organ donor coordinators into the hospital, getting ICU physician champions, promoting DCD, we've really, really risen. And so I'm going to skip over some of these slides. You know about most of this stuff, and show you that already year to date, as we said, we've done 132 deceased donor transplants. The most deceased donor transplants we've ever done in this province was around 120 or so, which was a long time ago. So we've come back, and we will have our best year yet for deceased donor transplants, and our living donor transplants are staying at a very high rate. So if you go across the country, you'll see that many programs will have a high deceased rate, but they'll have a low living donor rate, and the converse. Our success is going to be that we'll be able to maintain both. And so that will be delivering our patients the best possible opportunities to get transplants. So our number of transplants is increasing, but I did want to highlight one thing for you, which isn't necessarily as good. This shows us our challenge, and this shows, I think, how we can work together. Our waiting times and our transplant success rates in getting our A patients transplanted and our O patients transplanted has gone down. But if you look on the top slide, that's the number of people waiting, and the darker but not darkest line is our blood group B patients. But then in that same color on the bottom is the number of donors we have. So we have a huge mismatch between the number of B donors and the number of B recipients. So there are way more B patients waiting for transplant than there are B donors. And this shows you that the wait times have gone down for A's and O's, but B's, if anything, have continued to rise. And so there's a lot of B patients on the wait list. And so I'm highlighting this not to be controversial, but there is a high representation of blood group B in South Asians and in the Oriental population. And so we have a challenge to reach out into those communities and try to showcase what the importance of organ donation and the importance of organ donation, but be very, very sensitive to the cultural issues which are there. But I think we can make headway, and that's one of our first challenges which I'd like to take on. So most of our patients are getting transplanted, and they're getting transplanted more quickly. This shows you that at the end of 5 years, if you look at patients who went on the waiting list in 2008, at the very bottom is the percentage still waiting. So it's pretty good. But a lot of those patients who are waiting are highly sensitized patients, but I'll talk about that, I think, another time. Our success rates are great. A real success has been our kidney pair donation program. And just the last thing I think I wanted to highlight is the power of an individual who is altruistically motivated, who is willing to donate a kidney just for the better good. So most of the transplants that are done in the KPD program are done through these domino chains. When the domino chain is started by an individual who's altruistic and does not have a recipient associated with them, but is just willing to donate to help, they can set off that chain going. And this is the power of the chain. This is how many chains have been completed through domino transplants. And so they're started by an NDAD. And we've had a great success in BC. We have the most pairs registered. We've done the most transplants of patients for patients in the KPD program. And of all our pairs that have ever gone in, 60% of them have received transplants. So that's amazing. That's way higher. The next highest is down at 50%. But so, I'm surprised that. Oh, that's rate per million, because I didn't think that they had done that many. NL, I think, is Newfoundland. That caught me by surprise. And so the reason for this is that you know, we have NDADs rate. These people are called NDADs. The rate per million population in BC is the highest. So we can really capitalize on these individuals in our outreach and our public awareness to get the message that you can make a tremendous amount of good if you want in people's lives and with around being safe, around the safety of living donation. If we can pull that off, we're just going to lead to more and more success for our patients. So I just wanted to wrap up by saying that we've had some great success. We have some challenges ahead of us, but we have some really great opportunities. I think we have some clarity of vision in terms of moving forward. So we're going to build on what is a great program into being even greater. So welcome everybody to BC Transplant Days. If you want, you can root for the Blue Jays, and we'll see you later.